Welcome to our next session, Driving Diabetes Access and Equity in the Community. My name is Anna Norton. I am the Vice President of Community Engagement at the Center of Sustainable Healthcare Quality and Equity here at the National Minority Quality Forum. I'm very honored to be moderating today's session and would love to introduce you to this very, very special panel of esteemed guests that we have here today. To my left, Reverend Darian Henderson. He is with Trinity Baptist Church in Columbia, South Carolina, and part of our Faith Health Alliance here at NMQF. Next to him, Amy Hess Fischel, a clinician, a certified diabetes care and education specialist out of the University of Chicago Medical Center. Next to her, Mike Brown, a certified community health worker at the Shop Spa in Maryland, so right across the river. And last but certainly not least, also from the Chicago area, Israel Rocha, who is the CEO of Cook County Health, one of the largest health systems in the country outside of in Chicago. So just to give you a little bit of a brief overview of what we're going to talk about here today, I just want to share a little bit about what it is that we do at NMQF and at the SHC. Especially in our DRIVE program, where we're demonstrating real improvement in value and equity when it comes to people in minoritized communities living with diabetes. Some of the things that we hear a lot about in diabetes is all of the innovation that's out there. We've just heard the last couple of weeks about a new monoclonal antibody that will offset the development of type 1 diabetes. In certain people. So some of the things that we like to think about is how does that affect our communities? You know, so these therapies are beginning to come to the forefront. They exist, but are they getting to everyone in the right areas? And how do we change that? How do we go hyper-local, right? How do we get back into our communities and teach people and empower them so that access and affordability become one of the major issues at the forefront. And then, you know, we'll figure out affordability, right? So that's something, you know, and, you know, our minoritized communities are lagging there because oftentimes we don't hear what is out there, how we can improve our health, how we can make it better, how we can ask others in our own community how they have been able to manage and treat their diabetes, or how their families do that, how their communities help them do that as well. And so this panel today is going to talk a little bit about that. I mentioned a little bit about community engagement, the value of that, the value of peer support, the value of trusted individuals in communities, and how that can really move us forward in better diabetes outcomes. So I am going to just let everyone go down the line and just talk a little bit about the work that they do, and then come back with some questions. And this is meant to be interactive. It's meant for all of us to have a really good conversation. And then at the end of the hour, or with a couple of minutes, we will take questions from the audience. So I will hand it to you, Reverend.
Thank you, Anna. My name is Darian Henderson. I am actually the church administrator at the Trinity Baptist Church, Columbia, South Carolina, as well as I'm a lifestyle coach for diabetes prevention. And those two roles play together because I think because I have contact with a lot of the congregation, not only on Sundays, but on a day-to-day basis, because I'm dealing with day in, day out operations of the church. Sometimes my pastor think I'm trying to be the pastor, but I'm not trying to be the pastor. It just comes with the territory. But it's been such a rewarding experience to have that interaction with people. And as a result of that, I've got about 20, 25 persons that I lead in a group session every Saturday on a research-based, CDC-driven program that tells us that exercise and eating healthy can either prevent or delay diabetes. And as I was talking with someone in the back, I'm not diabetic and I'm not pre-diabetic. I am pre-diabetic, but I want to educate people to the point that they don't even have to be pre-diabetic. And that comes through dieting, eating properly, and getting that physical exercise in every day. And it's only 30 minutes a day. That's all you've got to do, 30 minutes a day. Of course, you want to do more, but if you get that 30 minutes in per day and get your good balanced meal 3 times to 6 times a day, you'll delay, even prevent it from happening. So like I said, I have about 25 persons that we lead. And my key is awareness, engagement, and education. You want to make people aware of what's going on, and our ministry leader make sure that we get that information as far as making persons aware of what's going on and the disparities that are happening in our community, not only in the faith community, but in the community in general. And then having some education, because once you make them aware, you got to educate people. The Bible tells us that we're destroyed because of a lack of knowledge. So we want to educate people as well. And then we want to engage so that, that what we've taught them, what we've made them aware about, what we've educated them on, that they're implementing that in their life. So that's my special key of making it all come together, making it all happen, that awareness, the education, and then also that engagement. And again, kind of going back to being the church administrator, I'm seeing faces day in, day out. And then on Sunday, and I think I heard someone earlier talk about having someone that's trusted. So people want people who are trusted and are in positions of trust so that they can share information with and gain information from. So that helps to bring about that community, that engagement. They are wanting more to engage with you because they've built a rapport with you. And I feel that I've gained a wonderful rapport with the people at the Trinity Church. So it's just been a blessing all the way around.
Excellent. Thank you.
I'm always so excited to hear how the community aspect of diabetes prevention. So I'm so grateful for everything that you do.
Wonderful.
So thank you. But my name is Amy Hess-Fischel. I'm a registered dietitian and certified diabetes care and education specialist. That's the new term for diabetes educator. I wanted to just give you a little overview, and you may already know this, but it's good to hear it again, is diabetes self-management education and support. That's the technical term for diabetes education, is the God-given right for every single person that has diabetes. So again, it's really important that people do understand that Medicare, Medicaid, commercial insurances do cover the benefits of diabetes education at least 2 hours every year. But then the other part, as a dietitian, the medical nutrition therapy part, there's usually either 3 hours for that first year of being diagnosed, but also an additional 2 hours every subsequent year. Now, there's another piece of that most people don't realize, is that dietitians, they can actually get unlimited hours after those initial 2 hours every year. So it's just something that I'd love for you to spread out in your communities to remind people that this is a service that is that is something that is available to all people with diabetes. Now, again, as the Reverend, as you were just talking about the prevention, that's a very different piece. And so I work within an endocrinology clinic at the University of Chicago. Again, half of our population is a different ethnicity besides white. And again, I've been there for 15 years, and I'm really excited to say that just like diabetes prevention, diabetes education is also a relationship. It's also that ongoing piece. And I'm very fortunate to say that I've been working with some of the same people for almost 20 years, that they've kind of followed me for the places that I've been. And that is really that trust and what has to happen for someone to have this ongoing support. We know that with diabetes itself, it's not a one and done. We know that this is a lifelong condition that, to be quite frank, sucks. And so again, we have to acknowledge that with people and be open. Now, the national standards for diabetes self-management education and support is basically the mothership of every recognized and accredited program across the United States, meaning that they have this blueprint that they need to follow, these 6 standards that have just been revised back in 2022 that highlight the quality and consistency of care regardless of who you are. Now that we've been doing the national standards since 1985. Now I was not doing it then. I was, again, I started when I was 3. No, kidding, but no, again, it is certainly when we think of the scope of the national standards, it does a multitude of things. It does, continuous quality improvement, but the 2 big things when it comes to health equity and cultural inclusion is that standard 2 really highlights what is it within your service that you are doing to meet the needs of that community. So that's 1. That every single service needs to be assessing on an annual basis. Now, if Medicare ever came in to audit the programs, these things have to be in place. So that's why they always have to be assessed. Then finally, the most important piece of this puzzle is that patient-centered care. So every single time that we're seeing a person, that we need to be assessing them for what their needs are, not what we care about, but what their needs are. And so again, those national standards have been designed to include everyone. Now, we have to acknowledge the fact, I have to acknowledge the fact that diabetes education, if we look at some older data, only 6% of the population with diabetes are getting diabetes education. Why is that? I've had some really hard conversations with people in authority saying that it's probably us. And we have to really take a much better understanding of why aren't these people coming back? What is it that we need to do? And so I'm going to stop there. But again, I think that, one of our quality improvement program pieces that I want to do at the University of Chicago is how are we better integrating the community within a clinical program that we have. Because again, as I said, diabetes education is ongoing. Once they leave us, I still need to be able to find other sources and resources that they can use. And so again, I'm hoping, my dream, of course, is that how do we integrate this? I'd love to see it globally, but again, nationwide right now.
Thank you, Amy. And I definitely want to come back after everyone speaks and talk a little bit more about patient-centered care, especially in our communities. All right, so I have a note. Okay, Mike.
Hello, everyone. I'm Mike Brown. I'm the manager of the Shop Spa. That's a barbershop. We've been in business for over 21 years. I've been the manager there for 13 years. How did I get here? Dr. T, I met Dr. T. I was in the barbershop, and in 2010, he came to me, and I was working, and he said, do you know that you possess a strength that you're overlooking? And I was like, Dr. T, what are you talking about? I'm here every morning, I'm cutting these hairs. He said, no, I'm talking about the relationships that you have with your clients. And when he told me that, it was like another eye opener. I was like, wow, he's right. And we could be feeding them the health information that's needed for our community, which overlooks their regular health. The community that I'm in, that I work in, the people like, the guys, they really won't go to the hospital unless their arm is like about to fall off. Then they go, then they want the attention. So our barbershop, we serve maybe 800 to 1,000 people a week. It's a very popular shop, lucrative, all types of conversations going on. We have brought the health disparities. We started to challenge the health disparities in our barbershops, and it's moving across the nation. It actually took a pandemic for us to be recognized. We turned our barbershop into a vaccine clinic when no one in our community was getting the shots. I called it the hell no ball because they were saying, hell no, I'm not taking the shot. We had to get educated through Maryland University, the School of Public Health, Center for Health Equity, under the director, Dr. Stephen Thomas. He gives us the information and we give it to the community. I was on the Hell No Wall. So I was one of the community that was saying, I'm not taking it. But I had to stop talking and do some listening. And when I began to listen, I began to learn. So the same way I had to unlearn and relearn is the same message that I'm bringing to my community from my platform. It's an honor and a pleasure to be here, and I'm not going to hold you up too much longer.
Thank you. Thank you so much.
Yeah. Thank you. Good morning, everybody. My name is Israel Rocha. I'm the CEO for Cook County Health. Our health system is the third largest public health system in the United States. And we operate several divisions that allows us to have a unique perspective that I think could bring some insight to our partners. And one thing that we have gotten from that insight is the need to develop community health. But in our work, we operate two of the largest. We operate Strozier Hospital. If any of you have ever watched the show ER, that's the hospital that it was based on. It really introduced hospitals to America. We're about 200 years old, and she still looks amazing, our hospital, because of community support and all the community helps to build it. And so it's a level 1 trauma center. We also operate Providence Hospital, which was the first Black-owned and Black-managed hospital in the United States in the south side of Chicago. And it's about 150 years old, and just it is resilient and growing today to make sure that we continue to serve communities on the south side of Chicago. We also operate CIRMAC, which is the Correctional Health Division. So we provide we care for more detainees than any other health system in the United States. We provide all care for individuals who are in detention service in Cook County in the city of Chicago. And through that, we see a lot of comorbidities and a lot of undiagnosed issues come to life that we get to see. We also operate the Cook County Department of Public Health. The public health department system in Cook County is broken in half. County is about 5 million people. 2.5 million are cared for by the city of Chicago, and 2.5 million are cared for by Cook County Health in the suburban division. And then we also operate an insurance plan that has about 500,000 members, and it's called County Care, and it's the largest Medicaid managed care plan in Chicago. And then we operate an innovation center, which is really what I'm here to talk about today, called the Change Institute. And what we have seen through all these programs is that for some reason, while we have done amazing things in healthcare, I mean, today I can take a swab of your cheek and tell you what diseases you're likely to have and what to do about it. However, the inequity that we have seen that truly exists is that we still have not changed the front door of it. And so while we keep adding to scientific discovery and we keep making things so much more powerful, you still have to get through the front door of health. And that starts by seeing a provider, even if you have insurance, and we continue to do better and better. And Illinois is an amazing state. We're about to hit, whether you are documented or undocumented, a full coverage state in every possible way, whether we just were the first state to have, if you had a childbirth event, you get coverage for 12 months no matter what. If you are over the age of 41, no matter who you are, there is a coverage plan for you to be able to have some kind of coverage in the state. And so it continues to grow. But we're not creating more doctors and we're not creating more access. And that means that people still have to wait a long time to get through the door. So in the Change Institute, we said, you know what? Why don't we start to change that conversation? And that resulted from one thing. I went online and I wanted to figure out how we could raise money to change the way that people get through that front door. And I found easily $50 million to tell us why social determinants were bad. Not really to do anything about it, just to talk about it and to talk about inequity. I found less than $100,000 in small micro grants that allowed health systems to actually change something to do it. It's why for now almost 30 years we've been talking about social determinants forever. We all know, you don't need to tell us, that there are challenges in our communities that are not being addressed. But yet we still keep talking about it and people keep getting paid for it. And they spend millions coming into communities that they're largely never really there and talking about it, and then they leave. And then more people come in and they study again and they leave. It's time to start changing the structure. And that's why we said the Change Institute has to change. We have to make it easier for people to get into healthcare. And I say something that sometimes people look at me like I'm a little strange. I said, I want to make healthcare as easy as fast food. And people look at me, they're like, you can't be talking about healthy and fast food. And I said, well, why not? Why shouldn't I be able to go through an easy way on my way home and say, you know what, I'm not feeling well. I want some lab tests. Maybe I won't do my colonoscopy today, but I will take some other tests that will be done. And eventually, yes, I will do a colonoscopy too and other issues. That's really what needs to happen. And we need to empower. We talk about the wonderful power of community healthcare workers, but yet we don't want to seem to let them have tools. So at the same time, I believe we should have community healthcare workers, but we should give them apps. People talk about, sometimes there's a digital divide, and somehow that our communities or communities who are often disadvantaged can't get that information. And then I laugh and I'm like, that the greatest enrollment source for SNAP benefits, which these individuals that we're talking about is through electronic means and through apps. They're using it. They get free cell phones, an iPhone 7 if you need it, because we learned very early on in other places that it was easier to give people a phone to get them to get their SNAP benefits so that they wouldn't go hungry. And yet in healthcare, we haven't learned those lessons. So what I think and what we need to do is to change the process and the way we engage healthcare. You heard testimony from powerful leaders. We'll have powerful resources. So why wouldn't I want to give the barbershop access to information and apps that could say, look, go online and get this information? Why shouldn't we be able to do events that diagnose treatment at large events where we have congregations and individuals there who could have trusted voices, understand that this is safe and needed medicine so that we can get there? Because the reason that people are dying is we saw it in COVID, and we knew it before COVID brought it out to the front. Mm-hmm. We have a lot of uninvited guests in our body. Again, we just seem to not want to talk about them. And we really don't know until we're in the ER because our family member had a kidney failure problem. And then they found out, my grandfather still tells me, before he passed, he told me to his dying day that he got diabetes at the hospital. And I'm like, oh, girl, you didn't get diabetes at the hospital. He's like, oh, yes. When they told me my kidney wasn't working, they gave me diabetes. That's sort of what happens. And so I think the process that we're working on is how do we change it? Equity will not be accomplished if we keep doing the same thing and hoping for a different result.
Absolutely.
And we haven't changed the front door. And that means that we still need people to sign up to go to a doctor. We still need people to go places. And I can tell you right now, if we keep just creating insurance and not changing the process, hospitals are still going to want to treat people who pay better and who have better paying plans. And if you're not creating doctors, you still have a problem. So we need to find ways to engage our community to be able to be more powerful, to have it be easier to see people. Our goal is to create a universal health app that allows people when they're tired and they're at home to be able to go online and say, I'm not feeling well, see a nurse hotline who refers you to a 24-hour access point, a clinic, a pharmacy, somewhere to draw your blood work. And then tomorrow in the morning, in between on your break, you can see a doctor who has the full panels, who can tell you what to do and then tell you where you can pick up your medication. If you have diabetes, they can tell you, here's a treatment center. They're going to help you. They'll onboard you, and here's what you need to do. And if you have any questions about it, here are some other groups that you can talk to. You still can come to us. We'll send a healthcare worker to you. And here's what they are going to do and how they're going to treat you with videos and education and treat you what you need and bring your medication, because it needs to be easier to get medicine. If you're wealthy and you have assistants, doctors, people, they'll get you in quickly. I know. My family still calls me. My family's from Texas. Every day I get a family member who calls me like, hey, this happened. Can you get me into a doctor? I can't see someone. They said it was going to be 2 months to get in, but I'm scared. Can you please get me in? And I have to make calls and we get them in. But that shouldn't be the standard, and it shouldn't be special. It should be equal for everyone. Mm-hmm. And so that call should be to an application that says, I can help you immediately, and I'm going to help you to use these resources better. That's how we create more access when we don't have enough doctors. Using powerful people in the community who can help steer people where they need to go, help them go over the fear of needing that information, letting them know. Part of why saying that we have illnesses is empowering, because then people say, well, if they have it, maybe I can be okay if I have it too. And they're doing well, I can do well too. That's why talking about it in barbershops is important. And that's how we start to change the conversation. And that's how we start changing the way medicine works. Medicine has to work for the patients. At Cook County Health, I tell my team one thing. I want to hit the same standards that Cleveland and Mayo Clinic have. And that's how we achieve equity. But we're not going to get there the same way. My patients can fly into me from around the world, and they don't have all of the money that they have, but the goal has to be the same. If the readmission rates there are X%, they need to be X% at our location. If being able to diagnose and treat a condition is a certain way, we need to do it a different way. And it doesn't mean that it's any better. It doesn't mean we're going to follow their model. We're going to be better because we're going to be able to treat our patients, but we have to find our own way to get there. But the outcomes need to be the same. If we try to just replicate what they do, I can tell you it's going to fail. And I also told them, I said, you think that they have it easier? I've worked at both hospitals, an affluent hospital and a lot of public hospitals, and I can tell you that I prefer our public patients because both of them have very complicated positions. Try to get an executive, or one of us in this room probably, to go in. No, I have to speak here. I have to do this. I have 10 people depending on me. No, I can't sit an hour. Everybody has their challenges, yet those challenges are being resolved, and the people who are disadvantaged are not. And so we need to change medicine. So the Change Institute is looking at how we can use powerful voices in the community, powerful tools to make medicine work, and stop forcing everyone to go down one path of medicine only that clearly is not working and is resulting in every city, we call it the tale of two cities. You have one city where people are dying in their 60s and 70s, and those are usually 80% brown and black communities. Then you take the most affluent part of the city. In Chicago, that's Streeterville and the Gold Coast. They live to almost be in their 90s. It's a 20, 30-year deficit between the difference. And we know what it is, just like we knew in COVID. It's cardiovascular disease, it's diabetes. And diabetes is the largest one because it's the next things that you hear is diabetes, pulmonary function, and neurosciences, all which are conditions of diabetes and renal failure. So it's perpetuating all those things. So we don't get our arm around diabetes. That's a problem, but we have treatments for those. We can get you healthier. You can manage diabetes if we catch it early. And we're missing the opportunity. So our goal is to find a way that we get people in sooner. We test them. We get them the treatments that we need, and we can change it. Because we sometimes talk too much about etherical things. And I said, we need to solve social injustice, and we need to solve housing problems. As a hospital provider, it's to fix just one part of the city in housing will be about $5 billion. That investment needs to be made by the government, and we shouldn't stop fighting for that. I don't have $5 billion. That would be my whole budget. But I can be very powerful with 20, 30, 40, $100 million to get people treatment and get them to be faster. I can tell you this, the largest, fastest growing individual who is dying faster than anyone else. When we look at who is dying the fastest, it is people of color. In those, it is often women who have undiagnosed disease, especially in cardiovascular, men in renal function, and you're having them die. My issue is you want to make change, you want to solve social determinants, give a family back their matriarch or their patriarch for another 5, 10, 15 years. I promise you, you will start to see some changes. And that's what I think we can accomplish.
Thank you. Thank you for sharing that, Israel. I want to address some of these conversation that has sparked some questions in my mind, and bringing back to the hyper local, right? The work that the Reverend does, the work that Mike does, and how can community leaders help to facilitate the conversation, to get people to walk into the door, to go see Amy, right? To receive their entitled 2 hours a year of diabetes education. They're entitled to it, right? It's covered, right? How do we get them to go to the healthcare system, make that appointment? So how can we do that starting in the local community? And if anyone can speak about that, I think that we deserve to hear that so that we can replicate that across this.
Well, I think I think sometimes we feel like we're not qualified. As I was sharing with my healthcare leader, Vivian, who's actually here, the Lord had laid on my heart to join the health and wellness ministry. And as I joined the ministry and got involved, I had that, again, because I already had the rapport because of my position, you just get more involved and help people to like I said, education. You got to help people to become aware and educate them and engage with them on a constant basis to help them to understand the importance of the disparities with diabetes as it relates to what we're doing right now. But there's so many different disparities that we deal with in our community, but especially with the diabetes. In the pandemic, I had 3 friends, close friends, that died as a result of diabetes. And they didn't have to die. They were younger than me. I'm only 49, and they were about my age. And one was younger than me. That it should not be that way. So my question is to myself is, could those lives have been saved through education? Getting them to understand the importance of healthy eating and getting some fitness in. It's just a question that I ask myself. So I qualified myself by just saying, hey, if not someone else, why not me? So you've got to see yourself as, you got to empower yourself. You got to self-empower yourself to do the work, and then do the work. Get the education that you need, and then do the work.
And Mike, you said something earlier about unlearning what you had learned, right? And relearning things. And do you see that in the shop, where you're constantly unteaching some of the myths and misconceptions about diabetes in your community?
Absolutely. We definitely advocate the information and the education that we get from School of Public Health. A part of the delivery to the community, to a stubborn community, is that you have to become water. I mean, you have to really humble yourself all the way down to fit the shape of the container so you can cover all the bases. You have to become them. You have to talk to them at their level, put it where the cows can get it, and like really talk them off the cliff. And, you've been eating this way for 25, 30 years, however old you are. So I'm not going to be able to tell them that information one night. It took them 30 years. They've been eating like this, and stop it in one night. So it's a consistent battle of waking up every day, going into the shop. I'm going to be water. I'm going to be persecuted. They're going to talk about me. They call me all types of names, but we all a family. I've been cutting their kids. They grow up, they have kids, so it's generational. The relationship is there, the respect is there, the information is there, and we just filter it to the community one by one. And we definitely have seen some results. People are like turning the corner now. Well, I'm not gonna eat that right now. I'm gonna back away from that. So it starts with those little things. And for my community, I found out that me being a member of my community myself, I'm more of a visual learner. If I was to see like the pre-signs of diabetes like on a chart, and I could identify with that chart, hey, that looked like something I could have, that strikes a conversation right there. So my mirror on my barbershop is full of literature, and I always turn them to the mirror, and I'm pointing them to the little pamphlets I have around the mirror, and it strikes conversations. I have clinical trial information up there, diabetes, lupus, colorectal cancer. We cover a lot of disparities in the barbershop, and it's a perfect place to do it because the community is stubborn. As I reiterate once again, my community, they're really not going to go to the hospital unless their arm is falling off. I mean, literally, and that's something that we have to change.
Well, that's very inspiring, and to think about learning visually. One of the things that we hear a lot about in diabetes are all of the innovation, right? All of these devices that are out there. And oftentimes, and I'm not just speaking about minoritized communities, but the general public doesn't always understand what these technologies or these devices can do. And to sometimes see that, and for you to have it on your mirror, for example, to see what a continuous glucose monitor could do in understanding what blood sugar does, or what food does to blood sugar, or exercise, or sickness, illness, something like that. And to see a graph, right? And to see that those numbers, especially with devices, Israel, you were talking about, or someone was talking about cell phones. You were talking about cell phones, right? And to have a continuous glucose monitor connected to your cell phone where you have your information, you literally have it in the palm of your hand. And, you know, I think that it's very encouraging to hear that you have something on your mirror where people can look at it and maybe ask questions. Now, do you find in both of your communities that there are questions being asked, or is it more just listening?
Both.
Both.
Questions and, you know, that interaction going on. And that's where you learn and kind of get the temperature, gauge the temperature when you see interest, when you have webinars or sessions that's dealing with certain disparities, and you get instead of having like 4 or 5 people, you may have like 20 or 25 people, person showing up. So I think it's that in both of them mixed together.
Great. And Amy, you talked before about being patient-centered, right? And that's something that we hear a lot now. We're hearing a little more and more, right? The patient is at the center of the wheel, and the spokes go out to everyone else, right? Oh, yeah. Right? So the patient is the important person.
Always.
Right? And you said something like, it's not what I want as the clinician, it's what does the patient want? What does that person that lives with diabetes want? So when we talk about being patient-centered in minoritized communities, we also have to think about food and culture and family, right?
Absolutely.
So when you get them into your clinics, how do we address that? And how do you address that?
All the time. You know, I think that, you know, it's supposed to be a conversation. You know, I think that, you know, if I look back, and I audit diabetes programs across the US, and, you know, when I hear from some of these services and they say, I'm not really sure why these people aren't coming back. And then when I look, it's like, well, you're just talking at people. You're not listening to them. You're not asking questions that they can respond to. And I think that's really what diabetes education, in my mind, that's how I function. This is a conversation. This is about, how can I help you today? What are your frustrations? And I want that honest dialogue because, you know, again, I don't live in your shoes. You don't live in my shoes. Let's talk about what is it that you need and go from there. And so when we think culturally, yes, bring in the family. Who do you live with? Who's doing the cooking? You know, because of the world that we live in, I do a lot more virtual visits. And what I love about that is because I can say, pick up your computer, or let's walk into your kitchen and let's take a look in the fridge. Let's take a look in the cupboards. Let's talk about, what are you doing? Give me a flavor of your life. Let's walk around your house so that I can kind of see how you live. And then we can really have that discussion, because I think that diabetes education in a bubble isn't going to work. You know, just doing this checklist of all the topics, that doesn't mean anything. You know, again, we have to talk about, what is it that you want to talk about today? And it might be nothing. You know, again, we have to acknowledge the fact that, you know, we need to get to know each other. We need to get to you know, understand what is it, and that my job is no judgment. Let's just talk about what you want to talk about today and go.
Yeah, that's a great approach. And if we could see that across the board, right, in all of our communities and all of our health systems, you know, but we are here, right, to affect change.
And I think, you know, I mean, what you mentioned before is, you know, again, my job is, you know, I work in a clinic, and, you know, again, I'm not out, but I'd love to see more diabetes centers having a relationship with community individuals, because I think that's where, you know, then, you know, we each have trusted sources to go to and say, hey, let's, you know, again, what are you hearing from the guys? You know, again, you know, I'd say, how much closer can we get them before their arm falls off, and we can get them into the office? So I think, you know, and what other resources do you need for diabetes prevention? I think that, you know, again, we do have to, and Israel, you said the same, is that we have to kind of really take a different approach. That, you know, yes, I hate to say we do work in silos, but again, we need to change. We have to change that, you know, again, every single thing that we do, it's all about that person with diabetes. It's not about us. It's about, you know, what can we do to help each other to make this happen? Because that is the only way it's going to work.
Yeah, and you brought up a great point about trust feeling trusted or being in an environment of trust. And so when we are with our communities, we may feel more compelled to share. And when we share, other people will share as well, right? So oftentimes, I'm Hispanic Latina, and in my community, we don't talk about mental health, for example, right? That's a big issue. And we don't talk about diabetes, right? But if one person talks about it, then everybody says, oh, you too? Right? So when we are in our communities and one person speaks up, there's probably half of the room that is thinking, oh, I wish I could have asked that because it's happening to me. And so that's the power of being in a room where you feel enough trust to share. And that's what we're doing in these hyper-local communities. That's what's happening in the barbershop chair, and that's what's happening in the churches. And I think that that's very, very important to drive people to go see diabetes educator, certified diabetes care and education specialist, sorry, and to make appointments that need to be made so that we don't have Israel talking about comorbidities and about people dying way before they have to die, right? We all have to die. We just don't have to die sooner than we need to.
Right.
And I think that, I mean, you even brought up, yes, I love for every single person to have diabetes education. And I know that may not be a reality. But again, if there is a way that we all can support each other to get you the resources that you need on an ongoing basis, still moving that needle. Again, we're still going to see outcomes. So, I think that it's going to be a win-win no matter what. So it's not just everyone has to go to diabetes education. What do we do with those folks that aren't going to?
I would say that's an important distinction because we all talk about mortality rates. We're all going to die. So I can tell you eventually everyone's going to have a mortality rate. It's just how we get there. I'd love one day that we were talking about immortality, but we're not quite there yet.
Yeah.
But I think one of the things that doesn't exist that much is how you monitor who's dying faster. In our public health department, we created a new health atlas. It's tied to our Change Institute to look at who's dying faster because that's not talked about it. To look at where those communities are happening. And then just one of the things that I don't want to miss the opportunity to connect is that the power and the opportunity that we have before us is what you said, I can tell you right now, a confession, because you can't move forward until you know what's in there. We're not as good as we could be in the provider's room. We have too many patients to see often. You can't build the relationships. And that's why the opportunity that I think could be healthcare's Amazon or Lyft or seamless moment or any moment to change something dramatically and be a disruptive force is to move that entryway further to our partners, to the barbershop or to others. Because what we haven't done is that, all this is predicated on knowing that you have a disease. I talked about that we have secret and tutors. Denial, trust me, it is a powerful force. You can be like, not me. They may have it. Everyone around me may have it, but I don't. And you convince yourself. And until you're ready in a place and open to hear it, they may be ready in the barber's chair to hear it if they heard everyone in the room saying that thought that you said was in the back of their mind. What's missing is we're not connecting. What I would love to see is that then, right at that moment, when you think you've connected, you give them a link to an app that says there is somewhere here. Go talk to the nurse or the hotline or the educator or the doctor. They're available right now. When you need them, they'll be there for you. So that when you're in a large setting of parishioners and what they can do, we can either have community healthcare workers who test them, one. Secondly, if they are, we can tell them it's okay, here's the information, talk to them immediately. There is a group of people waiting to see you. You don't feel well, here's the close to a doctor. That's the connection that people want. And people talk about concierge medicine, patient-centered care. If you don't know that you need to be a patient, we're failing. So the reason we're failing is not the intent. We're failing because we are failing to connect those opportunities. And the community empowerment and hyperlocal approach must be partnered with healthcare so that we can give that access. And the front door needs to move from needing to come to see a doctor when you're with your arm falling off, because it's the only time we're going to go because our life is busy. What people also don't understand, it's tiring. Like sometimes fast food works. Again, I always say the fast food because sometimes you don't want to go to the grocery store and cook when you get home. You're just tired, so you're going to stop, pick it up, and be done with it. Healthcare needs to have that accommodation. Or you're only going to see people when you're about pass out because you're starving. And so you need to find ways to make it work. The opportunity is I would love to see the front door of medicine be at the barbershop or at the church. So then we can help people know their medicine.
Clearly, collaboration is key, right? That's what I'm hearing down the line. It's just continuing to enforce that, continuing to recruit community health workers, continuing to spread the message of what we do at NMQF, what members and leaders in our communities are doing to encourage change, to affect it, and then to see those numbers change, those mortality rates change, right? The number of instances, the number of issues, renal failure, for example, right? As it relates to diabetes and so on and so forth. I have one last question, and you can answer it however you like, and then we're going to open it up to the audience to ask questions as well. I just want to know a little bit on your thoughts about how can we accelerate some of the access to the innovative and then the transformative therapies in our communities. How do you think we can do that? What is your thought, your ideal thought of how that would work? Things that communities are not seeing.
Well, Anna, I mean, if you don't mind me starting, you were talking about the new monoclonal, that just came out to prevent type 1 diabetes for at least 3 years. The biggest issue with that is finding those who actually are at risk, and that requires screening. And so the only way that we're going to be able to get this into the communities that we need to identify whether they're at risk or not is you have to do mass screening. And that's, again, that's going to be a tall order of how to do that, and I think, that's just one example, when it comes to that. But I think, in my world of diabetes education, standard 1 of the national standards say that we need to have external stakeholders that are part of our service to be able to give us input. And I'd say, if I was living in these two gentlemen's neighborhoods, they would be on my list because, again, we need to have that external input. And I think that as diabetes education services, we need to be engaging the communities more. But, the bigger, my organization needs to be engaging it across all levels. And I know that's my pipe dream. But, again, that's what.
Any other?
And I would say also education, going back to education again, in our community, we have a high community of seniors. So giving them and when the pandemic hit, everything went virtual. What is a computer? What is a laptop? What is a tablet? Which, our congregation had to become very familiar with. So, but having that education on how to turn the tablet on, how to turn the laptop on, and then providing them continuing education classes on how to work computers. To now today, we've got at the Trinity Church about maybe 20 or 25 seniors who are engaged in technology, and it kind of helps them when they're going to the doctor to work these iPads. And it's disheartening when you go to the doctor and you see a senior and they've got an iPad. And the nurse, the person at the front desk, just gives the person, the senior, the iPad to fill it out their information, and they are clueless. So at the Trinity Church, we've given them the education when it comes down to technology. So if you want to learn, we have it available so that if you have to get a device, innovation integrated in your life, you even at least got foundation.
Absolutely. And that even opens the door to telehealth. Absolutely. Right? So
absolutely.
It's raining, it's snowing, there's a tornado, you can't get to the doctor, you have no transportation. Right? And that now you can access your clinician through telehealth.
Absolutely.
Right? Which it was happening before. We're seeing it a little bit more, but certainly not enough. Mm-hmm. Right? But that's a great point. Mm-hmm. Right? And that is for some transformational.
Exactly. It has been transformational at the Trinity Church. I mean, the whole church took a curve, not only just with health, but just in general.
Any others, Mike, Israel?
Go ahead.
What I would say that I think we just need to do is continue building the connections between each other and the resources that we have. And from the healthcare perspective, in our providers, we need to recognize the power of the community networks that are in existence, but really tie those networks, because we do have telehealth, but it could be much more powerful if it's tied to a community healthcare worker who can then tell someone how to use it, who then can be activated by a parish or by a barbershop individual who knows what to do to say immediately, here it is, let me get you in. Because that's what I think is missing, is the connectiveness of everything. And when I say we haven't had our Amazon moment, whatever feelings may be about it, I can get almost anything delivered to my house today. That's different. I don't even have to go anywhere. And that has solved a lot of things for a lot of people. And now in healthcare, from our health plans perspective, we use that sometimes. We're even now using on food apps that only deliver healthy food and we'll pay for it. So from a perspective, we can tell you, you know what, we're going to give you this app. You're our member for our county care plan. And if you get hungry and you're food insecure, you get free food. But the caveat is we're only going to have a panel of restaurants that are going to give you some food that's not great. And we need to make better. I joked about before that my sister was trying to be healthy and cooked a gluten-free cornbread. It had more in common with a basketball than a cornbread, but we can get there. So I think we can get there together. But, I think that we need to recognize the power of each other and our voices and what we can do, and then have immediate tools for immediate activation, because we often think they'll be activated somewhere else. And if I have you at that moment where you may be willing in the barbershop chair to go in, he needs a tool. I can't rely that it's going to be someone else. And any tool, just get in the system. But he should have the tools. We should have an army of community healthcare workers ready to test people and then connect them if they find out that they're diabetic, so that they know that they are, so the denial stops. And it may take a few tests, because I had a patient but a patient in our system who our doctor was telling me about, who went to 8 of our offices, because we have different locations, to get a diabetes test, hoping that the response would be different. And that's a difficult moment, and we have to figure out how to work. But imagine if I could partner them with a good educator, a community healthcare worker, to help bridge them. So I'd say we need to do better at connection.
Absolutely. I just need to, I'm like where the rubber meets the road, where the information comes from the great panelists here, and I'm where the rubber meets the road. So I just need to continue to be humble and continue to learn and advocate.
Excellent.
Find like-minded people that wants to get on the journey with me.
Absolutely.
So we have time for 1 or 2 questions. Does anyone have any questions?
Here.
I can't really see. It's really bright.
The other side.
Okay. Other side. Okay. Yes.
Hi, I'm Tim Swope, Johnson & Johnson, and I have a question for Reverend Henderson and other panelists if they'd like to weigh in. Reverend Henderson come from Columbia, South Carolina, which is one of the deadliest zones for when it comes to complications from diabetes. Specifically, one of the things that I'm working on is peripheral artery disease, and just the very high rates, especially in African Americans, on amputations. I was wondering if you work with your community on just raising awareness for the need for screening for peripheral artery disease in patients that do have diabetes. And just for anyone else, if this comes across your radar, being in the diabetes. Thank you very much.
Yes, sir. Not so much dealing with the peripheral artery disease, but Columbia, actually the church is in 29204, and there's an article, and please go and Google the article about amputees, the state,
yep.
The state paper, correct, that talks about diabetes being, I think, for 10 or every 10,000 is diabetic. And we're actually right in the middle of that. That's what I'm trying to say. Our church is right in the middle of it. So we don't so much deal with it in my community, in the faith community, in the church, but we deal with it in the community itself. But I've not really come across anyone who has dealt with an amputation or something of that nature. But it is definitely, it goes back to, again, that education, and being that we're in a place where it's not only a health desert, but it's a food desert. You don't have access to good, healthy food. You have the general dollar. You have the Family Dollars. You have all those little small box stores where people have access to things that are not really going to help them. And it's really sad. Please Google that article, and it talks about the 29203. Again, my church is in 29204, so it's right in close proximity of the church in the Richland County area. And again, it just goes back to our heightened awareness of educating. Again, I take it back to the Bible. My people are destroyed because of a lack of knowledge. So what we've got to do is that we've got to continue to educate and make our people aware and help people to understand that you can be an advocate as well. It doesn't take much. You don't have to be an expert. I don't have to be like are all the wonderful minds that are in this room. But what I can contribute is what I can contribute. And that's what we got to show people and educate people and push people towards, because you've got to do it, because it's the way that we're going now is just not going to be helpful, and it's going to be very detrimental to us.
Thank you.
In any form, and to be power.
Absolutely.
You know
Okay. I think we have time for maybe one more question.
Hello.
Hi.
I'm Risa Motley Reynolds, president of the Charles McKinley Reynolds Jr. Pancreatic Cancer Pain Management Initiative. Type 2 diabetes, which my husband had before he realized he had pancreatic cancer and lived only a month after discovery. So what research are you doing for early detection for type 2 diabetics and the comorbidity between pancreatic cancer and diabetes, especially type 2 diabetes after 5 years? Because his doctors were lost. They were trying to control that 500 that his diabetes numbers went up to, rather than testing him for pancreatic cancer.
No, and I'm so sorry to hear about your husband. You know, I know, and in fact, we lost another patient who was diagnosed and also had pancreatic cancer. And this is a difficult condition. And, you know, again, I don't have any answers, you know, and certainly talking with the physicians that I work with, you know, again, it is at the forefront of, you know, because of how quickly that this progresses, you know, and again, I applaud you for for doing what you do. God, you're doing God's work. God bless you. But I'd love to hear more, you know, so I'd say I'll talk to you after.
You know what I would add, one of the things just for your question is that today we talked about one aspect of what we're doing the changes to, which is getting access. And that's important because then we can get individuals. But there is one other part that we don't talk about as much, is that those higher ends of medicine that we talked about, that higher standard, full comprehensive review, sometimes isn't done as much as it should be done at all patients. So one of the things that we're working on is making sure that we bring genotyping early on to figure out why someone has early onset markers for diabetes. There is panels now in our endocrinology clinics that immediately test to find out what's happening, why and where it comes from, including pancreatic cancer testing early on to figure out if there's anything else happening with the body, and then starting advanced trial institutes that will be able to get people some resources. But it starts first by diagnosing and testing. And, you know, part of my frustration, and I didn't talk a lot about it today, but I don't like the word social determinants when it applies to patients, because oftentimes you're telling someone they're determined to die early or they're determined to have diabetes. And a lot has been taken away from certain communities that we shouldn't be taking agency as their provider. Social determinants has a purpose in a community. There's social risk factors in the clinic, and we can mitigate those risk factors. And it's incumbent on us as health systems to do those tests so they're there. And sometimes they're not done. So I would say keep advocating, but what we can do and what we are doing is ensuring that the most advanced testing is occurring when someone has a comorbidity, to rule any other indicators out and to find out what else they're at risk for, given that they now have a heightened comorbidity, and what we can do to test it to create the most advanced processes available to them possible.
Thank you very much.
Thank you. I want to thank all of our panelists here today, Reverend Henderson, Amy Hess-Fishel, Mike Brown, Israel Rocha. I am humbled to be on this stage here with you and hear about the work. I encourage any of you to come and speak with anyone here on the panel. Everyone will be here for the rest of today, but also to visit with some of the members from our Faith Health Alliance and from our Hair Wellness Program. I see Stephen Bishop in the audience. Everyone can talk about what they are doing in their communities. It's valuable, it's meaningful, it's life-changing for communities. So please reach out to them, visit with them, get to know them, learn about what's going on in these communities and how NMQF is helping to empower these communities to move forward. Right now, we are working with 23 health systems in training healthcare workers and 154 clinics. But we need that number to continue to grow. So I encourage what everyone here on the stage is doing, but what everyone is doing in the community, and if there is the ability to continue to empower communities to do this kind of work, we need to step it up. So thank you very much. We are here. I think it's lunchtime, right?